to go through all of psychiatry as quickly as possible. So this is pretty breakneck. The way I've done this in the past is to just run through the main, so obviously the whole of psychiatry is difficult to cover in an hour and a half, however long we've got. They always say, you know, the educational theory is that you can only maintain concentration for 20 minutes, but I find the psychiatry revision lecture the one where people's concentration is really good, actually. Please don't, you know, when you, I remember this as a student sort of coming away going, I'm sure she put loads of emphasis on that bit. I'm really not putting loads of emphasis on anything. I'm just running through all the psychiatry and the standard questions that happen. And I was asking in the lecture this morning if people wanted me to do OSCEs, and the general feeling was yes, yeah. The nurse has said not before, but that's fine. I usually do talk about OSCEs as well. I think in a way, that's more useful than the MCQs. I think that's one you can change a bit more. You know, some MCQs, a lot of it's knowledge or not, isn't it? Whereas OSCEs, I always feel is a little bit more kind of technique and focused. Please feel free to ask questions as we go along. I hope all the answers are correct. Some of these, I was looking at them last night and was thinking, I'm not quite sure I actually knew the answers to all of them 100%, but I think I do. We'll get going. So, the main categories. Psychiatry is, you know, fairly easy to revise in some ways because there aren't that many subjects, and we do try and emphasise that you should be able to answer questions that an F1 would know. So you're not going to be asked anything esoteric about, you know, recent research or stuff about, I don't know, brain scans in monkeys. You don't need to worry about anything too postgraduate at all. This is definitely an undergraduate exam. And the main things we're going to ask about are things that, you know, fairly obvious that you'd be expected to know in as a safe F1 seeing patients in casualty, for example, or as an F1 doing a psych liaison job. Hopefully, yep.
You have a microphone here.
It's meant to be on. Is that working? It's not working. Not working? Try the other one. Is that one on? No.
George.
There's always someone who's that's not working, is it? No difference. You remember that for the rest of your life. Get back to the screen. How did you get back, George?
Press S5.
So, lots of these fairly obvious, probably the mainstay of anything you need to know is about depression. And lots of these actually are the case for SBAs and for OSCEs. So if there is one OSCE station that you're crazy not to be able to do, bang, 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 in the same way that you'd have to ask the questions about chest pain, you need to know how to diagnose depression. You know, whatever OSCE station you have, it's likely that they'll expect as part of it a screen for depression. So just being able to do this, test each other for depression. You've got exams coming up, you're allowed to score. But just practice it so it's like bang, 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 so you can just come out. So that's the Vygotsky. For SBAs, it's more classic features, epidemiology. I'm sure you've been told this before, but there's nothing easier when you're setting an exam than a list. So if you're coming across lists, try and remember, know them, and things like the following can cause depression, the following may cause depression, etc. for organic causes, iatrogenic causes. Features of mania and how they are different to depression, and the main management of mood disorders are all important. So these, yeah, just know these and know how to ask them. I see some of you writing this down. Do you want? I can put this, send it around to everyone, send it to Mel. Poor concentration, reduced confidence, guilt, hopelessness, and ideas of self-harm. And then separately, the biological symptoms, somatic symptoms. Be able to just reel these off. Be aware that the epidemiology of depression is difficult because it's such a broad diagnosis. But certainly for major depression, it's about 2% per year. We do know for sure, if in an SBA though, they're saying the lifetime prevalence of depression, if you have about 1 in 5 in your head, that's for all types of depression, major, moderate and mild, but it's worth remembering. And a lot of this is common sense, lower socioeconomic class, urban living, life events more common in women. In terms of the list, it's a very long list of things that can cause depression, so organic, biological, physical symptoms, things, and medicine that we give people. The one that is the most likely to mimic depression and really look like it is hypothyroidism, but all of the others can, and all of these drugs on the right are particularly recognised to cause depression. Steroids can do both, actually. They can make people go manic. A question I've seen a lot in exams generally are list of symptoms and then being asked what the most likely diagnosis is, and it's mania. So things like high mood, believing that you're special powers, that you're talented, or if you're psychotic, that you're actually, a member of your family or about to go and get an Oscar. Increased energy, talkative, flight of ideas. What's flight of ideas? Jumping from topic to topic, but there's a link between them. Decreased sleep, and in extreme cases of psychosis. Does anyone know the difference between mania and hypomania? No psychosis for hypomania, that's right. It's a matter of degree, essentially. I mean, it's a bit arcane to have to know exactly what it is, but if someone's in hospital and psychotic and sectioned and all of that, and there's a choice of mania or hypomania, go for mania. If there's a significant impairment functioning, then it's going to be mania rather than hypomania. The differences between the two are essentially bipolars. 1% of the population, that's major depression unipolar there. Male or female, the age is lower, and there's a much greater monozygotic to dizygotic ratio than practically any illness, really. I mean, psychiatric or non-psychiatric, a 5-to-1 ratio of identical to non-identical twins is pretty stonking, isn't it? It's difficult to think of any condition. It's got a more of a genetic heritability without being autosomal dominant. I don't think many people realise that. In terms of management, it's worth, if you have time before the exams, I think, just running through nice guidelines of the common conditions, not just for psychiatry, but everything. To have an idea, because you're everything, the common everything. I'm not saying everything in the world. Things like this is coming off the path of psychiatry, but it's useful to know the main nice guidelines for things like people presenting in primary care with hypertension, with chest pain, with the really common stuff. I think, because your examiners will know them, because they'll have to, and they will have them in their head. So it's, dare I say, worth knowing anyway. I know that's sensible. You probably don't care what's worth knowing when you qualify at the moment, but it's actually worth knowing. As a psychiatrist, I find it surprisingly worth knowing, because when my patients come in and all sorts of, combinations of different cardiological drugs mainly, it's worth having some idea. So for depression, do you know what the guidelines are for mild depression, treatment-wise? Exercise is, so sort of, I wouldn't say exercise as an answer question, but sort of general supportive stuff. But mild would be CBT, and then moderate, sort of SSRI plus or minus CBT, yeah. And then if it gets more severe, you move into secondary care. CBT is an answer for everything, I think. So if there was a question that said the following may be treated with CBT, or if the following may be, I find it difficult to think of anything really that CBT won't be on that list. Probably come up something in the exam now, and you'll be sending me nasty emails, but it's pretty good for most of them. And ECT, do you know who we'd give ECT to?
Severe.
Very severe, biological, refractory, not eating, drinking, psychotic, morbid elderly, often on section. Because usually people who get it are quite ill. I didn't talk about it because I should have said I'm not doing a thing where I'm just giving you the answers and then checking your short-term memory 2 minutes later. So I've covered some things, but what the reason we're up here is the things it's probably worth having some idea about. So etiological factors in depression. So which way do monoamines go?
Down.
They go down. So monoamine, easy to remember that. You're low, your monoamines are low. Which way does cortisol go? Up. So because what does stress causes? Raised cortisol is linked to depression. The other three. Does anyone want to? It's quite hard, this question. Sorry, I'm just scare you with a really hard one. Three of them, but all three of them I think are plausible, but one of them there is good evidence for. Childhood separation. Yeah. Childhood separation from parents is good evidence that leads to later life depression. The other two, actually, it doesn't. Although they sampled, they were those three, the one that there's evidence for is the third one. In depression, anhedonia refers to real bond. What's the meaning? The mood is objectively dysphonic. Everyone looks confused. Let's move on. Mood's always worse in the morning. That would be the typical biological pattern, but you can get the other way around. Poor concentration suggests an organic cause. Poor concentration is part of the features. Acts of self-harm suggests coexisting personality disorder. I mean, half the time it does, frankly, but not in exam night. And then, so what does that leave? Mood is objectively dysphonic. Do you remember when you're doing mental state examination? It's like objective mood, euphonic, dysphonic. Why we can't just say up, down, I don't know. That's medicine for you, isn't it? Come up with words that mean this. I know we don't normally have nots in the exams here. We're told to try not. Have you heard this? That we're told to try not to set questions like this. The odd one comes in though, but not often. But it's helpful for revision anyway. So tricyclic antidepressants. Which of these is not due to the anticholinergic? Hypotension, which is due to alpha-adrenergic effects. So all the the rest of these are the anticholinergic effects. And if you remember, do you remember this? It's not just psychiatric drugs, but there's a whole load of drugs that have anticholinergic effects. And you should, like pattern recognition, see these and go, yeah, dry mouth, hearing retention, blurring vision, constipation, they're the anticholinergic cluster. A 31-year-old lady, oh, it's got a bit squashed up there, sorry, with sudden onset irritability 2 weeks after giving birth to her baby. She thinks the baby's destroyed her life, and reports to be hearing people saying bad things about her baby. She may have a point about moving it, but anyway. Joking. What's the most likely diagnosis? Purple psychosis, yes. And so again, examine. You see this a lot in exams. So the difference between baby blues, which happens when a few days after having the baby, completely normal, thought to be due to fluctuations in sort of hormones. Postnatal depression, which is essentially like depression, but happens in the postnatal period. Some of the things that you use to diagnose are more difficult because you ask someone with a new baby how she's sleeping, you might get hit if you don't ask it properly. Obviously she's not sleeping, and the weight's going to be up and down and all of that. So it's slightly more difficult to diagnose, but it's still important. And then purple psychosis is really important to know. But this is when, as soon as it's psychotic, there's nothing in that to suggest. Well, I mean, I suppose it could be schizophrenia, but the fact that it's sudden onset, that's 2 weeks after giving birth, you know. Okay, that's the whole of depression covered. Moving on to anxiety disorders. Again, can come up in either OSCEs or SBAs, and I should have added to that, and I've put some slides up there about it, a bit about the sort of medically unexplained symptoms, so I'll talk about those as well. So those are the main 4 plus medically unexplained symptoms. Generalised anxiety disorder. So this is a fairly common question, is a description of someone with anxiety symptoms. And then you have to decide which of them it is. So is it anxiety or panic or agoraphobia or whatever. And it's fairly easy, really, to remember the difference. So everyone knows what anxiety is. You're probably feeling it a bit. If it's generalised, it's persistent, free-floating, people say all the time. Phobic, it's one specific thing, which mainly you don't even see in psychiatry, fear of spiders or whatever. That's very common in the population. It's not something that people normally go to doctors about at all. Panic disorder, recurrent attacks, severe anxiety, well-defined, episodic. They can just come out of the blue, or they can be due to, they can happen in a certain situation. And then there are and especially agoraphobia is when you're more likely to become anxious and panicky if you're out of the house. And specifically things like public transport and stuff like that, and then stop leaving the house because they get more anxious. The other thing that you might hear about is social phobia, which is essentially a medicalised description of being a bit shy. Suddenly came into the ICD when they decided to license the SSRIs to treat it. I'm going to talk about hyperchondriacal sanitisation separately. OCD, when you have obsessional thoughts, so when you get recurring thoughts in your head that you can't kind of turn off, but you know they're irrational. So that's the difference between obsessionality and psychosis. You know that you're being silly. And I think, has anyone not had to go back and check a door that's locked, knowing it's locked, but going back anyway? That's an obsessional thought. And then medics have a really high rate of obsessionality and obsessional symptoms compared to the general population. population. So a little bit of obsessionality can be quite good. But what happens is when you start going back again and again, and you're getting late for things, as you're going back and going back, that's when you start getting into OCD. Talked about that, panic disorder, the physical symptoms. You feel that you're dying, you feel that the world's about to end. It's very unpleasant. And you get people who come into casualty with thinking about having a heart attack, and actually it's a panic attack. You used to be told to blow into a paper bag, but I think there's been some research recently that says that's not true. Does anyone know about that? Apparently it doesn't help. But I think, again, in exam-land it probably still does help. But I read recently that actually someone actually went back and looked at the physiology and did a sort of RCT, blown into paper bags, and it's forget that. Yeah, very unpleasant. And so it's worse. Sometimes they can come out, but they can be precipitated if you do want to ask people about things like caffeine intake, that kind of thing, because that can sometimes cause people to have panic attacks. No symptoms of anxiety. Phobias, just saying, yeah, more common in women, more onset at less than 7 years old usually, and usually a particular thing, but generally, or I don't know if you'd almost call it a mental disorder. It's so common to have a phobia. It's phobic. We've talked about these. The common obsessions are feeling that you're contaminated, being worried about getting ill, worried about your own safety or safety more commonly of family members, having to make sure everything's in line, perfect, is all obsessions. So just say, common in the normal population, but can get out of hand. You know what the treatment for OCD is? CBT and SSRIs, a higher dose than for depression, so you go up higher to like 40 milligrams rather than 20 milligrams in SSRI. CBT can be very, very effective, very satisfying, and the compulsions. So I mean, basically what happens is you get the obsession, so the wanting to go back and check the door's locked, your anxiety level goes up. The only way it's reduced is by going back to close the door to check it's locked. You leave, the anxiety level goes up again, and you've learned that the only way to reduce your anxiety is to go back and check, and that's this pattern that people get into. So how does in terms of rituals, how do you think CBT works? So say I am going back to check 20 times. How would you stop? What would you do? Yeah, you have to wait. You have to not do the thing and wait for the anxiety to go. So you might even need to have someone with you, dragging you away from the house. Or what a really brave therapist might do is make you leave the house open. You get people, who are scared of spiders, and you make them grab some spiders. Hope they don't have a do you know what that's called when you really immerse a person in the experience? Well, flooding is the one where you actually flood them with the thing that they're scared of and just let them wait there as the anxiety goes. That's the quick one. You really would worry that someone's just going to have a heart attack there. And then systematic desensitization is when you go for spiders, for example. Talk about spider, picture of spider, fluffy spider, real spider. That's the way. It's really effective. Unexplained symptoms is a sort of anxiety, and that's another question when you get a sort of example of someone who's, I don't know, going to the GP a lot with physical stuff, and they want to know which it is. It's quite difficult to remember this, I think. So I think the ones that are more difficult to get your head around are probably the first two, and maybe hypochondriacal disorders, which you don't normally hear mentioned as in exams, but it's worth remembering as well. So Munchausen's, you know about Munchausen's, it's when you're just making it up for no obvious reason than to get medical attention. Malingering is the sort of person who's making it up, but for an obvious reason. So you know when you see people in papers who are off sick on benefits, and then the papers see them, I don't know, skydiving or something. Yeah, that would be malingering. Somatization disorder is when you have lots of somatic symptoms, so lots of medical symptoms, all different parts of the body. So you have one who goes to the GP with a bit of chest pain one week, and a bit of really bad headaches and legs, and so there's lots of going to the doctor. You're not making it up, you're not malingering, probably what it is that people who are just, there's a relationship between stress and physical behaviour, and there's people who are just more sensitive to that than most. Conversion disorder are the dissociative ones. So the way to try and remember that is that you're converting your psychological distress into a physical thing. So the classic example would be someone who has just seen a horrible murder and goes blind. So they're converting their distress into that. And then hypochondriacal disorder is one that many medical students can probably identify with, where you've got a mole and it's melanoma, you've got a slight tension headache, and it's a space-occupied lesion, expected. Does that make sense? And you need to go. You're going to GP asking for scan after scan after scan. Whatever symptoms you have, you will pick the most serious and dangerous one and decide that's what you've got. So we talked about all of these, cognitive relaxation, behavioural medication. You often get families who are kind of colluding with obsessions, especially. So, entire families who will all strip naked and shower at the door before they come into the house. Honestly, it's amazing what families will do. I'm not an expert at all, but when I had a patient who I did CBT with when I was in SHO, and she was always ringing up her husband and her mother, asking really awful questions. Her poor husband, she kept ringing her husband up and asking him if he thought it was really bad if she thought he was ugly. She was really asking him that. Poor guy, they'd only just got married. Anyway, so I had lots of supervision. It was like all her family and her husband, all her friends actually were all coached to say, Dr. O'Brien says no answer in response to practically everything she said. Because otherwise she would just get the reward of I know. And it worked, because she stopped doing it. That was probably great. Because she'd shown her wedding photos at work, and one of her colleagues has said about her husband, he's no oil painting. I know. And she developed an obsession about it. Poor guys. Anyway, a 44-year-old woman presents with a 3-year history of multiple physical symptoms not explained by any physical cause. She is preoccupied by the symptoms and seeks repeated consultation. What's the most likely one? Somatization, yes. So she's not coming in saying, I have got this. She's just, maybe worried about everything. A 43-year-old woman suffers from panic attacks when she goes to shopping centres and watching television. What's the most likely diagnosis? So it's out and in. So it's not going to be agoraphobia. If it was in a shopping centre and then she hasn't been out since, it would be agoraphobia. Panicked. But I think lots of people would look at that, see shopping centre and put agoraphobia. In agoraphobia, those sufferers are married, men affected more than women, panic attacks common, teenage autism teens, and association with social phobia. Which do you think is most likely? So it's not, they're usually married, actually, and often develops later on in life, which gives you an answer to D, which is wrong, because teens would be early to get agoraphobia. Men more than women? No. So panic attacks uncommon? No, they're the kind of core thing that. So, association with social phobia. It makes sense, doesn't it? You don't like going on buses, you're not going to want to go to a party, are you? It's sort of this. Okay, next one, suicide and self-harm. Suicide is when it results in death, and DSH is self-harming, self-injury, irrespective of the purpose. So its definition depends on rely on the outcome. There's lots of press about young men being at risk of suicide. There is a bit of a peak, but it's still always older people who are the highest risk, especially older men over 70. Especially if they're divorced and widowed, again, living in cities. You're more likely to kill yourself in spring and early summer. I don't know why. And more common in lower socioeconomic classes. There are lots of other either precipitating factors or relationships, living alone, being unemployed, drugs and alcohol use, and mental and physical illness. Quite a number of people who commit suicide don't have any mental illness. It's not a given by any means. DSH, incredibly common, deliberate self-harm. 7% of the population at some point harm themselves, which is really high, isn't it? It's the 5th most common reason for admission to medics, and it's a different sort of demographic. Women, younger, again low socioeconomic class, single. Only 30% have a diagnosed mental illness. So superficial self-harm, especially in adolescence, in response to life event stresses, is actually common. 1/4 will do it within a year, so which says that 75% will come in, will do just once, but and it has to be taken seriously because 1% will manage to kill themselves over the following year. In 40% of self-harm, alcohol is a factor, and half of people who've completed suicide will have self-harmed in the past at some point. Men and women tend to use different methods. You don't see car exhaust so often anymore, actually, but those are international figures. But certainly women are more, at the moment I think, females are more common overdose and males are more common hanging for completing suicide. So, which of the following is not a risk factor for completing suicide? Being married is easy, too easy. Associated with suicide? That's a bit harder. So, going through the process of elimination. We know not winter months because I've just studied spring summer. Does anyone know about times of war and the research about that? Less likely. At times of war, there's more social cohesion, and you're less likely to kill yourself. You're less likely to kill yourself at times of war. The idea is that people are more kind of, Dunkirk spirit, everyone's in it together, less likely to kill yourself. I suppose the other way you could argue is that if you're suicidal, you could volunteer. That's not the official reason. So not times of war. Upper social class? No. So which one is it? Bar workers or high cholesterol? Bar. Low cholesterol, bizarrely, has a link with suicide. But you wouldn't need to know that arcane fact, because you can work it out from, it's going to be, of those two, it's obviously control. Okay, we're going to rotate schizophrenia now. Some of you had to hear talk about this morning. Psychotic illness with abnormalities of thinking, perceptions, personality, speech and behaviour. And we split into positive symptoms, delusions, hallucinations, thought disorder, which is where people's thoughts are jumbled up, and for alienation and passivity. Those are the cluster of symptoms when people have thoughts taken out of their head, or feel that your thoughts can be broadcast. Passivity is when you feel that someone's taking over control of your body or your mind. And then the negative symptoms, which are in some ways more difficult, lack of drive, slowness, social withdrawal, self-neglect. You should all know what a delusion is and be aware of the main types: grandiose, persecutory or paranoid, bizarre and nihilistic is an unusual one, but it's worth knowing about it when it's very, very negative. And the main epidemiology, as I say, some of you heard me say this morning, it's about 0.8% of the population. All cultures were more likely to have an earlier onset in young men. I think it's worth knowing the main side effect profiles of the typicals and the atypicals. And while I'm on medicine, two medicines that are very easy to ask questions about, both in SBAs and OSCEs, are lithium and clozapine. So I think it's worth running through those. I don't think you need to know the different drug names necessarily, but know the sort of side effects of each. You know, the main side effects of conventional typicals versus the side effects of atypicals. And I didn't say it before, but I would also say that I'd do that for the SSRIs and the tricyclics as well. I don't think you need to know about any other type. I wouldn't bother with the other antidepressants, but the main side effects of all those four. So tricyclics, SSRIs, typicals, and atypicals. And the atypicals, clozapine's a special case, but all the others you've heard of, probably Sertindol's just, I should take that off, it's not really used much anymore. They all act on dopamine, but the atypicals a bit more on 5-HT. The main difference between the atypicals and the typicals are the fewer extrapyramidal side effects, have a lower rate of tardive dyskinesia. However, they have all their own problems, especially metabolic syndrome, massive weight gain, more likely to cause diabetes than the typicals. The typicals, conventional ones, the main one you see is haloperidol. They are more effective than you think, given that they've been sort of so surpassed by the atypicals. The reason for that is because of tardive dyskinesia, essentially. You know, the abnormal movement, spatial and hand movements that you can get if you're on a long-term typical antipsychotic. Can happen with the atypicals too, but much less likely. And because it's irreversible, I think that is the main reason, quite a good reason why people would go usually for the atypicals as a first line, which is what the NICE guideline says. Yeah, I mean, this is all fairly common sense. If you saw this in the question, it would be fairly obvious that, cognitive therapy, a bit, supportive therapy, all of this. There's some evidence for all of them. In terms of etiology of schizophrenia, we know, like most things, it's multifactorial. There's a genetic component. Life events come into it a bit. we also know that there is a link between drug misuse and schizophrenia. Yeah, see, well, yes, let's see. There's a question about that, so see if you know the answer. Cannabis as an accepted cause of schizophrenia? Probably not. I think that would be putting it a bit, I mean, lots of psychiatrists would say that, but it's probably putting it a bit, cannabis, certainly B is, if it was between A and B, or the first one or the second one, which one do you think is most likely to be right? Cannabis is an accepted cause of schizophrenia, or cannabis is an accepted precipitant to relapse of schizophrenia. It's going to be the second one, isn't it? Some psychiatrists would argue A, but it's probably not something we'll get into in exams yet. Amphetamines cause schizophrenia? Yeah, well, that's a bit of a nasty question. Amphetamines cause a schizophrenia-like psychosis. You get amphetamine psychosis. It doesn't normally last as long as the symptoms would to pick up a diagnosis of schizophrenia. Do you know how long you need for symptoms to get schizophrenia? Weeks. So you'd have to be on a lot of amphetamines for a long time. Abstinence from illicit drugs leads to resolution of symptoms. Can do, maybe not, it depends. So that's just a bit too categorical, your response to say yes. And a dose-response effect is seen with cannabis and degree of psychosis. How would you test that? Can you imagine asking for evidence for that? I'm going to give these people stronger and stronger, more and more cannabis, and then see how mad they get. It's just not realistic, is it? Schizophrenia, more common in some adults. Still no answers? False, more common in. And some people think it might be related to some kind of prenatal viral thing. I don't think you really know. It's a universally progressive condition. No, some people relapse or remit, some people have quite good outcome. More common in men over 65. Young men, but typically late teens, early 20s. And then you do get another sort of little blip in the over 60s, but then it's more common in women, late onset. More common in urban living. All psychiatry research makes you want to just pack up and go to the country. Everything's more common in urban living, in urban births. Incidence, same in all countries. There are pockets where the incidence of schizophrenia is more than in others. I don't know, I have to remember this one. Well, so there's some country. You can get a map, if you Google it, you get a map with this sort of order, the incident rate of schizophrenia around the place. America's higher than most places. There's sometimes it's to do reporting, so there's some places where there's just no schizophrenia reported. Ireland's higher than England. And then you get all the migration effects of separate populations and even to other populations where you get a higher incidence. I mean, that would be a bit hard to ask you that, really. First experiences thoughts for escaping from his mind and experienced by everyone around him, which is this. People get mixed up on this one. So is it withdrawal? Is it grandiose delusion? Is it ideas of reference? Who thinks it's thought broadcasting? Yeah. Who thinks audible thoughts? I just sort of made that up. And thought withdrawal. Thought withdrawal is when your mind goes blank. But thought broadcasting is when you think other people can read your thoughts. It doesn't happen very often. It's quite funny when it happens, and you sort of try to do an interview and the patient just sits there smiling and goes, refuses to answer any questions, just says, you know. Everything I I ask? It's happened a few times. I mean, so clozapine and lithium, know these because it's the sort of thing that you either know or you don't. It's easy to set. I have seen OSCEs in the past where people have had to explain clozapine and lithium starting to patients. Students did terribly. You'll see shocked faces. So is it once a week for 8 weeks and monthly? In fact, let me just do a show of hands for. Who thinks it's the first one? Who thinks it's the second one? Who thinks it's the third one? The fourth one? Or the fifth one? Quite a lot of hands didn't go up there. Okay? It's once a week for 18 weeks, then fortnightly until the end of the year, then monthly for life. You might think that's unfair, but you often see people on clozapine. So eating disorders, again, really easy as an examiner to set questions on, because you can have lists of symptoms and the differences between anorexia and bulimia. So know how to diagnose and know about the main physical complications. A lot of the core psychopathology is you're not wanting fat, but people with anorexia will have this morbid fear of being overweight and then with an unnatural body image and will be underweight and have a BMI of less than 17.5 with the secondary endocrine dysfunction such as amenorrhea. People with bulimia might do quite some of these as well, dietary restriction, overactivity and purging, but they're not. People with anorexia are a bit more obsessional, people with bulimia aren't quite as focused and will also binge and so often actually aren't low weight or are normal or slightly higher weight than they'd like to be because binging and purging it's difficult to lose all the weight if you are binging, if it's a big binge, you know. But people with bulimia, they're big bingers, they really are just unbelievable. And people with bulimia are slightly more likely than people with anorexia to use laxatives and diet pills and, you know, weird things you can buy off the internet. People with anorexia, it's more just don't eat and exercise. Well, there's a bit more than that. And people with bulimia are more likely to have a bit more of this sort of impulsivity, more risk of self-harm, more likely to use drugs, to drink. There's a bit more of that overlap with personality problems than for anorexia. It's all gone off the bottom, but I think I remember what it says. Physical complications, these are more of anorexia in those who are very low weight. Some of it's just the consequences of starvation, mainly as consequences of starvation, so they can have hypertensive, they can have heart failure. For the bulimics, it's the esophagitis and erosions from the constant vomiting. They get constipated secondary to the long-term laxative abuse. It kind of get this paradoxical constipation. You can get liver failure, renal failure, both. Amenorrhea is part of anorexia nervosa osteoporosis, so you can get fracture. I remember seeing a patient who broke her leg getting out of bed, which was pretty terrible, I know. And then she came to George's, and when she came back, she looked thinner, and she weighed more. And then it took us a while to realise, A, we'd forgotten that she had a cast on, and B, we hadn't factored in the fact that she filled the cast with batteries. So I remember the water out, everyone going, she is thinner, I don't understand. And fuzz all over you that you get in response to the weight loss. And the dental erosion to carotid swelling is typical of bulimia. And I think that to the bottom says, what is that called? Thyroid problems, which you can also get. Yeah. So those are the main. The other difference is people with anorexia nervosa, they can be so thin, you can't believe they're alive, and they're going, I'm fine, I'm fine. All I'm going to eat today is a big carrot. Whereas people with bulimia realise they have a problem. A classic question will be something where they've got some life-threatening complication and they really want you to know about someone who should be admitted. This is also a classic kind of OSCE station. And if they're very low weight anorexia, they need to be refed slowly. If you do it too quickly, they can go into heart failure. To be honest, the treatments aren't great. I mean, antidepressants work a bit, family therapy works in the younger age group. For bulimia, psychological therapies are the mainstay. And antidepressants, again, at higher doses can work in bulimia. As people have started using, some people use antipsychotics. I don't think I'd put that in an exam. And increasingly, sort of, people are aware that sort of just supportive management of people with anorexia nervosa over a long period of time can be the most effective. The outcome, as you can see, isn't great. Only about 40% recover, 20% go on to chronic illness, and mortality is 10 to 18% even with treatments. It's quite a tough condition. Whereas with bulimia nervosa, tricky this one because it's not less obvious, and people don't tend to talk about it much. But about half do all right, and again about 1/5 continue. But people will usually function with bulimia nervosa. You can function much better. So, which is the 20-year mortality for anorexia nervosa of those? This is a test of your short-term memory. Well, is it going to be 2% or 38? 26 a quarter, that would be a bit high. So it's going to be 15 or 7, isn't it? 15, yeah, I think I said earlier. Yeah, I think it said 10 to 15% in the earlier one, and that was 10 years. 16-year-old girl whose parents are going through divorce, been diagnosed with bulimia nervosa. Her BMI is normal, but she's hypokalemic and experiences arrhythmias. Which one would you do? Yeah. Yeah. You really don't want 16-year-olds running around hypokalemic and arrhythmias, do you? All the rest are perfectly reasonable treatments for bulimia nervosa if she wasn't having arrhythmias. What feature is not found in bulimia nervosa? Hyperkalemia. All of the rest of them are, and most of them makes, it's fairly obvious why. All of these are the effects of constant vomiting, but you're much more likely to become hypokalemic. Okay. Substance misuse and alcohol. Again, not just realised, but really likely to be in any OSCE that you would have to ask about, take an alcohol history. So I'll run through that when I do the OSCE stations, which we'll get too soon. Loads of people exceed safe limits, with 1 in 10 men and 3% women showing signs of dependence on alcohol. So I'm sure you don't only have to pick up pen to read about the sort of problems around alcohol. European society and the UK in particular. 60% of suicide attempts involved alcohol, half of serious road traffic accidents, 70% of homicides, murders, either the victim or the assailant's drunk, and 1 in 5 orthopedic admissions. I always think of a friend of mine who who had to be admitted here during rag week when I studied physician. Had to have about 4 operations. And her clerk-in was attended George's disco last night. Drank, question mark, dependency. Her parents weren't impressed. I do remember that. So how do you measure dependence on alcohol? Well, the main one to say physical dependence, the most important question is withdrawal. So you can be sort of psychologically dependent on alcohol. And I mean, you could argue that someone who has a glass of wine every day, I can't imagine going through a day without their glass of wine. It's a really middle class thing. The Archers is at 7 o'clock and they always think, well, a glass of wine. Some people would argue that that is psychological dependence on alcohol, but they're within their units and it's only a glass of wine a day. So it's, I think it should really, personally I think you should have to have harm at the end of it. But physical dependence is easier to establish, and if you need a drug, whatever drug it is, and if you get side effects, withdrawal effects, if you stop the drug, then you are physically dependent on it. Do you know which drugs cause a physical withdrawal? Someone's have to shout out. Heroin. Opiates do, heroin causes it, yeah? Alcohol. Benzos and barbiturates are basically it. So when you see people in withdrawal from, well, although I don't know if anyone's trying to give up smoking, that feels pretty physical, but when you see people in casualty with, I don't know, say they're coming off amphetamines or cocaine, that you don't need treatment, physical treatment. And in fact, even for opiate withdrawal, you don't be admitted to hospital for it, because although it's very unpleasant, there's no physical sequelae, dangerous physical sequelae from stopping heroin. The things which are dangerous are mainly alcohol, and to a lesser extent, barbiturates and benzos. But the main one is alcohol, which is ironic, isn't it, as it's about the only legal one. So with dependency, you start being unable to control what you're drinking, so you start to stop, you start getting what we call salience, so you'll stop doing other things because you're focusing on the substance, drink or whatever it is. And then Edwards and Gross came up with 7 points of what they described as dependence, which are pretty similar. The only thing that's they had were relief drinking. So that, when people drink, most people don't wake up in the morning thinking, what I really fancy for breakfast is a special brew. You're doing that for a reason. And that's what we call relief drinking. You're drinking to get rid of the withdrawal symptoms. And the other thing that Edwards and Gross noticed is that it's called reinstatement. So you get this with if you've been addicted to something, you're physically addicted to something, then and then you decide, and you stop, and then you try and go back. So someone who's been alcohol dependent tries to go back and just have a social glass of wine, they just can't go back within a couple of days on the sort of, 2 bottles of whiskey or whatever they're on before. Your brain is like, it's back. The receptors have been modulated and they want what they think they need to be happy if you have been dependent. This isn't just for psychiatry, you should know this for all branches of medicine. Long list of complications that you get after drinking too much, and then psychiatric complications. Alcohol's a depressant, it causes anxiety, hangovers are a very anxiogenic state. I talked before about self-harm and suicide, and it's linked with alcohol. Alcoholic hallucinosis is this state that people get in where they just very heavy drinkers who hear voices a lot. Don't see it very often, but it's just something you know about. Too much alcohol can cause dementia. DTs, delirium tremens, when people get psychiatric symptoms, then seeing things, become confused, secondary to stopping drinking suddenly. And Wernicke-Korsakoff, again, one of these just some things examiners love. Wernicke-Korsakoff is one. I would know the pattern of symptoms and physical sequelae in brain scanning for Wernicke-Korsakoff. What's the classic kind of thing that people will say with Wernicke-Korsakoff? Do you know? Ataxia is one. What else? Sorry? Ophthalmoplegia, yeah. Confusion. And say, how's his memory? Is it, what goes? Short-term memory goes, and your long-term is preserved. And confabulation, you know that? So you ask someone about their life, and then come up with a whole load of stuff that just sounds realistic, but they're just trying to fill in what's happened for the last 20 years of their life, because they're stuck. I remember one guy who, he'd been a pub landlord, and he kept breaking into his own old house that he'd lived in 20 years before. Changed a lot. His family getting really fed up with him, you know. I know. Kept finding this man in their living room going, who's changed the sofa? And I was a really junior doctor, and I had to keep telling him that his wife had left him, she doesn't really see his children. My dogs died. And yeah, after about the 5th time a day, I was really, I was breaking news to him all the time. But I stopped after a while. So yeah. I'll come talk to you in a minute. I got really good training in breaking bad news. Next time I'll tell him a bit more. But so they love. Nystagmus. We didn't talk about nystagmus. That's the other thing we get with. So you've got the Wernicke's, which moves on to Korsakoff's. And if you can catch it in time, you can stop Wernicke's movement to Korsakoff's. Treatment of alcohol misuse, disulfiram. You know, like some ethnic groups, if you drink alcohol, you get that red flushing face and you're sick. So disulfiram basically does that. It blocks aldehyde dehydrogenase. So if you drink any alcohol, you get that. And some people with alcohol bodies would rather just take this tablet every day, so that they're not tempted. If someone is really addicted and wants to stop, you can't just stop because it's dangerous. You have to do a detox, usually benzone, and make sure that people are given Valium at the same time. You hear about people being prescribed naltrexone, but I've seen anyone like that for ages. And then psychological treatments, motivational interviewing, especially at the pre-contemplative stage, so that's very much sold to GPs. You see this person, they're coming in with their forwards and whatever. You start from an early stage, starting talking to people about their alcohol. It's usually a gradual process that people will get to before they realise they want to change. They might have to have a few days that stop them before they do. CBT as ever, and lots of help groups around like AA. Drug misuse, I've talked a bit about which ones cause dependency. Again, nice lists of things that cause physical complications, the physical complications that you get. So some of the complications of the drugs itself, and sometimes are due to things like sharing needles, injecting, getting DVTs, abscesses, etc. And those are people who use heroin can get quite constipated. People who use cocaine a lot can get vasoconstricted. Probably see pictures of celebrities without nasal septums. The other thing that cocaine can do is cause heart problems. Always worth thinking about if someone comes in A&E young with arrhythmias, they will probably have taken something. I don't think legal highs would have made it into your exam. So for the purposes of today, they don't exist, but they do. A classic question would be that someone presents in some way and what they've withdrawn from. So you get horrible opioid withdrawal is a bit like really, really bad flu, apparently. And the dilated pupils are quite telling. You know, obviously, in a way, you get constricted pupils of opioids, so dilated one will stop doing that. A bit nasty vomiting diarrhea as well. The main treatment seems to be methadone, although that's a really, in my opinion, stupid thing for anyone, but that is what you will see. So people get given methadone instead of heroin, and often will be on methadone for years, supposedly at reducing doses. All of these others can be used. And again, psychological treatments. Okay. Nearly going through all the questions. Structures affected by corticosteroids typically include. Does anyone know? Familiar bodies, yep. Yes, easy. What do you think about that one? Do you think 70% of opiate addicts attempted suicide? Generally quite happy, I find. Oh. Do you think there's an equal class distinction? More common in women? No. Cases begin after 18? No. So by a process of elimination, even if you did not know that, that is the answer. Usually sort of personality problems. Not a feature of alcohol dependence. It probably is, but it's not a feature when you're looking at the ICD or anything else. So you've got a lot of high-functioning alcoholics, don't you? Just look at Charles Kennedy. You don't need to have a social life. And then I think this is last, dementia. Acquired global impairment of intellect, memory, personality, chronic, progressive, and irreversible. Nice and cheerful. Most common is Alzheimer's, then vascular, then Lewy body. A not unreasonable question would be like scenario of someone with memory problems, and you'll have to be told which one you think it's most likely to be. The clues would be the question. So if there's visual hallucinations, that's leading you, and Parkinsonian symptoms, that's leading you to Lewy body. If you've got stepwise progression and they've got cardiovascular symptoms in the question, that's mighty infarct. If not, Alzheimer's. That's rule of thumb. Over 20% of people over 80 have dementia. And you get all these features, many of which are fairly obvious, rather depressing, and the risk factors are on the left. So the general, I mean, again, fairly obvious that it's the general risk factors, things like hypertension and smoking and no exercise, anything that's going to make you more likely to have high blood pressure is going to make you more likely to have dementia. In real life, you know, in an exam they'll say, is it Alzheimer's, is it Lewy body, is it multi-infarct? In real life, people are usually a bit of a combination. And there's pretty good evidence that physical activity and NSAIDs, HRT in women are all protected. The mainstay of treatment, well, cholinesterase inhibitors for mild to moderate, it's not licensed for severe dementia. There's real problems, there's a lot of controversy about using antipsychotics in dementia, and people are being told not to, although sometimes it's really difficult, you know, people with dementia are very sensitive to the side effects, but sometimes it can be very difficult to manage people who are paranoid, aggressive, hostile, but there's a real move to not use them. And I think anyone over a certain age now seems to be on statin, so anyone with vascular problems will be on statin. Always important if someone is confused and older, especially to make sure that it's not a delirium, and the differences between delirium and dementia, another classic question. Anyone who's presenting with confusion, you would always want to exclude the organic causes first. By some of the things in the history would be a fluctuating consciousness, difference at different times of the day, tend to be worse at night, fear and agitation, and you'd want to do bloods, urine, always remember urine, chest x-ray, take someone's temperature, get an idea. If this is sudden onset and someone's older, you'd expect, you'd want to exclude some kind of infection. Okay, regarding dementia. That was easy. D, over 20% of the over 80s. Lewy body's not the most common. Unfortunately, very few are reversible. Can you think of reversible dementias? So I think part of dementia seems to be progressive, but one I always think about is hydrocephalus is meant to be, to some extent, reversible, isn't it? Okay, OSCEs. So just a few words about the OSCEs. Increasingly over the last few years, I've noticed that the OSCEs tend to combine more than one thing a bit more than they used to. So it will be often psychiatry with communication skills, for example. Just to make it real world, but it's, what do I say? I have seen it. It's quite straightforward. Am I allowed to say that? So it's a lot of the things you'll know already. I examined a lot of OSCEs. So just, you've been told all this already, but just some general stuff. It still never fails to amaze me what some people wear. And it's just, you just sit there and you're just trying to pay attention to the station and just looking at them thinking, what were you thinking? So don't wear any badges with anything saying anything on them. Don't wear any strange things around your neck. Don't wear short skirts. Don't wear low-cut tops. Really, just don't. Don't wear jeans. Try and look smart. You know, it's honestly really distracting sometimes. You just think, what's wrong with you? and then the people will collect yellow cards from every single station. Everyone's just going, skirt. Yeah, easy not to do that, really. No one wants you to fail. The other thing, occasionally people be really anxious and I sort of redirect them, you know, you're allowed to redirect a bit if you've got to handle that. I have had the experience of saying, why don't you read the question and actually answer the question, and they still don't do it. So really pay attention if your examiner interrupts you. The most common mistakes in psychiatry stations are people going in and you can almost see them thinking, right, this is psychiatry, and start asking, you know, so about their family history, where they went to school, tell me about your childhood, and it's just not what you're meant to be doing, you know, it's just not in the scenario. So just take a little bit longer to read the scenario. And often it will say in it, so it's very common, because you know, psychiatric history is quite long. It's very common in a psychiatric question for it to say, you do not need to do this. And it is extraordinary how many people then do what they've been told not to. It's amazing. So read, I know in a way saying read the question is obvious, but look out for those sentences where it says, you do not need to do this. It's probably my main tip, because you're just wasting time. And so the main mistakes I find are going into too much over-inclusive detail about past history, and then occasionally people who just don't seem to know any psychiatry at all, and any psychiatry at all give the impression that you've never been near a psychiatric patient, which does come across like that sometimes. It's how it is. Yeah, if it's not instructions, then do it. And the other thing is, if a patient doesn't seem to know the answer to a question, that's usually quite a good sign that you're on the wrong track, I think. They're quite well schooled. So if they look a bit confused, move on. I think the simulation patients are usually quite generous. When I've been in ones and they've said, sometimes if I think, oh, that's a bit harsh, it will nearly always be, if they feel patronised, that's my experience, is that they will not, I'm sure none of them will patronise. And you're always anxious at the first, you're wanting to know what's, you're trying to formulate what you're going to ask. So always start with a nice view, opening questions. Try not to introduce yourself like a robot. I know that it's really difficult because it's easy to answer at the beginning, but when someone goes and goes, hello, my name is, I'm 4th-year medical student, everything between us will be confidential. Is it all right if I sit down? And you can see them, yeah. So try and, try and do it like a human being. I know there's balance there, but yeah. And think about conditions that are most common to present. So these are the most common to present. There are some which, it's quite difficult to get someone who's really low weighting. It's really quite difficult to ask someone to be manic all day. So there are some who are more easy to ask than others. It's more easy to ask them to be depressed all day than be manic all day. This is just common sense, isn't it? And in terms, so whatever station in psychiatry you're asked, always ask about ask for depression, and always, if you're asking depression, ask about suicidal risk of self-harm. Again, there are some things that you just need to be slick at, and so depression. I think depression, suicide risk, and alcohol use would be the three. But I would just make sure that you are really comfortable with how to ask the questions and practice asking each other those questions. Acute confusion. I have seen stations, but that's, as you can imagine, quite tricky to do. But it is possible. But sometimes if it's tricky to ask an actor to your day, then you might be asked to get someone in, collateral of someone. That happens, and so often if it's dementia, the question will be of collateral. In alcohol, not just asking how much they're drinking, but the features to find out how dependent they are. So as I say, make sure you know all those. Everyone loves a cage. I was going to run out screaming if you use a cage, but if someone said already I'm dependent on alcohol, it's a pointless thing. It's a screening test to be used in primary care. You're not going to get marked down, but don't rely on it. Really important when you're asking about alcohol to get a quantifiable idea of how much they're drinking. Don't someone just saying the odd pint or social drink isn't enough. You have to try and get their units. And people who drink are a bit of an advantage there, I guess. I think because you just have to work out, how many units are in a pint of strong lager, how many neat lager. Oh, exactly. With eating disorder, you ask people about how much they eat an average day, their lowest and highest weight, current weight and height, and about binging, purging, periods. Again, it's a nice list. Mood and body image, and I think the bottom says suicide, I think. Cognitive state, I think it's, I think if bit hard. I don't think you'd be expected to do a whole mini-manifesto examination really without knowing it. I think a few years ago they had that, and I've been fine. Obviously, everyone freaked out. It's quite tricky to do from memory. But do know how to do a brief cognitive examination of anyone that you see. I think one of the things that people find most difficult to ask is about psychotic symptoms. The open question would be: is anything strange going on? Again, you know, they're not in an OSCE station going to try and make someone really guarded and impossible to get information out. That just wouldn't be nice, would it? So, anything strange going on? Anyone trying to harm you? Are you different or special to other people? Those are 3 questions. Not just 3 OSCE, actually, these are questions that I use all the time. They're kind of good screening questions to get into psychotic symptoms. And those are the questions to look for passivity phenomenon. You have control of thoughts and actions, to get some interference with thinking, and the things on the television, radio, but those I would have said was a decent delusion screen. And then hallucinations, are you troubled by voices, or do you ever see or feel strange things, hear things, strange things you can't explain? And again, in an OSCE, you'd expect a person to answer if they are. If a person is psychotic, again, you always want to check about suicidal thoughts and briefly about their drug and alcohol use. Anxiety is fairly straightforward. You know, you just need to, if you know the symptoms of anxiety, you can run through them. They'll be the same, but they're feeling. So, you know, you might say that someone's going to be feeling, well, you know, so tense. So you've got the mental symptoms of anxiety. So this feeling of dread, that something bad's going to happen, just worrying about things, people might not be able to sleep, and they might get the more physical symptoms like hyperventilating, feeling sweaty, you know, all those sort of physical things. What do you think people with anxiety might do to make themselves feel better? Drink alcohol. It's the most common, and it's going to make things worse in the long run, but self-medicating for anxiety symptoms with alcohol is very common. And so you'd want to try and support the person to reduce their drinking and manage the anxiety kind of at the same time. And obsessional symptoms, again, really, I used to find this really hard to know how to ask that. I sort of think, what do you say to someone? Do you have obsessions? So this is what I've come up with. Do you dwell on things? Do you have to check things? And I might even give an example. For example, sometimes people can't stop worrying about something and it goes around in their head. Or, for example, sometimes people have to go back and check that something's turned off. Does anything like that happen to you? Someone with OCD will know exactly what you're talking about. And that is, and just to say again, it's a mixture of things. So if someone's, like in your life, if people have anxiety symptoms, they're likely to have a few depression symptoms, might be using alcohol, depression, they might be. So just make sure you know those core questions and basics of the management of, as I say, depression, anxiety, alcohol. You're not going to expect you to know a lot, but the basic management. Any questions? I'm waiting here at the end for no doubt we'll have questions.